Welcome to Roadmap to Residency Evidence-Based Application. In this video, we will be discussing about adverse drug reactions and allergies. So, 25-year-old woman with a history of peanut allergy accidentally ingests a small amount of peanuts while dining out. Shortly afterwards, she develops generalized urticaria, facial swelling, and difficulty breathing. She becomes increasingly hypotensive and loses consciousness. Emergency medical services are called, and the patient is reported to the emergency department. Upon arrival, she is found to be in respiratory distress with stridor and hypotension. Which of the following medications is the most appropriate initial treatment for this patient's severe anaphylactic reaction? Oral antihistamine, IM epinephrine, oral corticosteroid, nebulized bronchodilator, intravenous antihistamine. Yes, you know the answer. That is intramuscular epinephrine. Anaphylaxis is a severe and potentially life-threatening systemic allergic reaction that requires prompt recognition and management. It is characterized by rapid onset and involvement of multiple organ systems, including the skin, respiratory tract, cardiovascular system, and gastrointestinal tract. In the setting of severe anaphylaxis with respiratory compromise and hypotension, the most appropriate initial treatment is the IM epinephrine. Epinephrine is the first-line medication for the management of anaphylaxis due to its potent vasoconstrictive, bronchodilator, and inotropic effects. It acts quickly to reverse bronchoconstriction, improve systemic vascular tone, and increase myocardial contractility, thereby reversing the life-threatening manifestations of anaphylaxis. Now, the videos on allergies, I have a separate videos on allergies and hypersensitivity reactions in our immunology module. You can go and watch that. So now let's talk about adverse effect of the drugs. Now there are different types of adverse effect of the drugs. We classify it as type A, B, C, D, E, and F. So type A is augmented pharmacological effects, that is dose related. Type B, bizarre effects, non-dose related or unpredictable. C, chronic effects, dose related and time related. D, delayed effects, that is time related. Type E, end of use or withdrawal effect. And F, failure of therapy. Now we will go through each of these adverse drug effects. So type A effects or augmented pharmacological actions are dose related to the pharmacological effect, predictable, very common, usually have low mortality, and can be minimized by optimizing the dose. It includes toxicity and side effects. Now, type A effects in more details. So type A have mediated by same receptors and same sites as for beneficial effects. Example, hypoglycemia caused by insulin, bleeding caused by warfarin, mediated by same receptors but at different sites. Example, prazosin controls hypertension by blocking alpha-1 receptors in the peripheral blood vessels, but cause pupillary constriction by action of alpha-1 receptors in the radial muscle of iris. So receptors are same but are at different sites. So it may be mediated by different types of receptors at different sites. Example, propranolol relieves angina via beta-1 receptors in the heart, but can also cause bronchoconstriction via beta-2 receptors in the bronchi. So different site, different receptor, different site, same receptor, same site. Type B is when there are bizarre effects which are uncommon. It is not related to the pharmacological action of the drug. These effects are unpredictable. They have high mortality, and there is no simple dose-response relationship. For example, allergic reactions. So abnormal responses related to the immune system. Type 1, immediate, for example, anaphylactic reaction with penicillins. Type 2, cytolytic, for example, hemolysis with alpha-methyl-dopa. Type 3, Arthus reaction, for example, serum sickness with streptokinase. And type 4, delayed allergic reaction, like contact dermatitis with penicillins, or it can be idiosyncratic adverse drug reactions. Now, idiosyncratic reactions may be related to genetic abnormality. For example, hemolysis by primaquine in GCSPD deficiency, apnea caused by succinylcholine in patients with low plasma cholinesterase, increased peripheral neuritis in slow acetylators during isoniazid therapy. Some more examples include acute porphyria, malignant hyperthermia, and other examples. Here we can see different sort of bizarre reactions of adverse drugs. Now, type C is a chronic effect, which is dose related and time related. It is relative to the cumulative dose and it is uncommon. Typical example is hypothalamic pituitary adrenal axis suppression by corticosteroids. Now, we may also include some drug induced diseases. For example, peptic ulcer caused by NSAIDs, nephrotoxicity caused by cyclosporine, hepatotoxicity caused by valproic acid, neurotoxicity caused by isoniazid. Now, these are some of the chronic effects due to corticosteroids. Now, Type D is the delayed effect. Now it occurs or becomes apparent sometime after the use of the drug. It is also uncommon, and the typical example is diethyl ethyl increase the incidence of vaginal carcinoma in office spring. Teratogenicity. Type E is ending of use or withdrawal effect. It occurs soon when a drug is stopped abruptly. It is also uncommon, and the typical example is opioid withdrawal syndrome and acute adrenal insufficiency via the sudden stop of corticosteroid, long-term corticosteroid. Now, type F is the failure of therapy, which is an unexpected failure of therapy, dose rated particularly when used, often caused by drug interactions. The typical example is failure of contraceptive pills due to concomitant use of a strong enzyme inducer, such as anticonvulsant drugs. Thank you for watching. Keep studying.